Okay, let's continue where we left off, and we were talking about pregnancy, early pregnancy loss. Now, in medical terminology, abortion and miscarriage are often used interchangeably to describe the spontaneous loss of a pregnancy before 20 weeks gestation. Understanding the difference between threatened, inevitable, incomplete, and complete abortion is essential for both diagnosis and management. Threatened abortion. Definition: vaginal bleeding but closed cervix. Threatened abortion: vaginal bleeding but closed cervix. Fetal heart tones still present, can still carry to term. Threatened abortion can still carry to term. Signs and symptoms: you have bleeding, which is mild, cramping, positive, closed cervix, yes. HCG labs rising normally. First line treatment for threatened abortion is pelvic rest. Monitor with serial HCG. Clinical pearl: fetal heart tone equals good prognosis, still possible to carry child to term or have miscarriage. So either way, threatened abortion. Then we have inevitable abortion. Inevitable abortion, open os. For threatened abortion, there's a closed os. For inevitable abortion, there is an open os. Vaginal bleeding with open cervix, no passage of product of conception, fetus will be expelled in inevitable abortion. Signs and symptoms: bleeding is heavy, cramping is strong, cervix is open. The fetus will be expelled. HCG labs decreasing. First line treatment for inevitable abortion is medical. Example: misoprostol, or surgical D&C management. Clinical pearl: there is high risk for infection or hemorrhage, will not impact future pregnancy. Inevitable abortion will not impact future pregnancy. Then there is incomplete abortion. Key POC, product of conception. FHT equals fetal heart tones. So there is, for the incomplete abortion, there's a partial passage of product of conception. Retained tissue visualized on transvaginal ultrasound. Signs and symptoms: bleeding, cramping. Bleeding is heavy, cramping is very severe, the cervix is dilated, plus there is still some tissues. HCG is low. First line treatment is misoprostol and D&C, dilation and curettage, till fully expelled all product of conception. Clinical pearl: risk of infection, septic abortion, antibiotics. So there's a risk of infection with septic abortion. Antibiotics if fever or foul smell in discharge. Antibiotics should be given if there is fever or foul smell in discharge. For complete abortion, all product of conception is expelled, including the fetus and placenta. There is no remaining tissue. Signs and symptoms included bleeding, cramping, bleeding which is resolved, cramping which is resolved, cervix is empty. For complete abortion, the bleeding is resolved, the cramping is resolved, and the cervix is empty. HCG lab returns to non-pregnant values. First line treatment, monitor for continued bleeding, should eventually stop. Clinical pearls: HCG should return to 0 within a few weeks. Placenta complications. Placenta complications are among the most serious obstetric emergencies, posing significant risk to both mother and fetus. We have placenta previa, which is painless bleeding. Placenta implants over or near the cervical os, blocking the birth canal. It is common in the 3rd trimester. And so you will see bright red vaginal bleeding, which is painless. There is no contractions. Assessment finding: soft, non-tender uterus. Fetal heart tone is usually normal. Treatment and management of placenta previa: stabilize mother, C-section if persistent bleeding, or complete previa in unstable patient. The clinical pearl: no vaginal exam should be done in a patient having placenta previa because it can worsen bleeding. Placenta abruptia. Placenta abruptia is painful plus rigid uterus. Premature separation of the placenta from the uterine wall before delivery. You're gonna have dark red vaginal bleeding, unlike the bright red vaginal bleeding in placenta previa. Sudden severe abdominal or back pain. Strong uterine contractions will be present in placenta previa. Assessment finding: firm, tender, board-like uterus, possible fetal demise or distress. Firm, tender, board-like uterus, possible fetal demise or distress. Stabilize the mother with IV fluids, oxygen, blood products. Emergency delivery should be done if placenta abruptio is severe. Risk factors includes hypertension, trauma, cocaine use, smoking. Hypertension, trauma, cocaine use, smoking. Fetal complications: fetal hypoxia, preterm birth, or intrauterine fetal demise. So these clinical pearls: risk factors includes hypertension, trauma, cocaine use, smoking. Fetal complications: fetal hypoxia, preterm birth, or intrauterine fetal demise. Breast concerns. Breast complaints are common in primary care and distinguish between benign conditions, infections, and malignancies. It's critical for patient safety. Rapid recognition of key features such as pain, discharge, or suspicious skin changes. Guideline diagnostic and appropriate managements. Let's look at some of these breast conditions. We have mastitis, fibroadenomas, and breast cancer. For mastitis, you have acute infection and inflammation of breast tissue, most often seen in lactating women due to milk stasis and bacterial entry. Common bacterial pathogens include Staph aureus, can progress to abscess if untreated. Signs and symptoms of mastitis include unilateral acute pain, swelling, localized warmth, erythema, fever greater than 101, flu-like symptoms, and malaise are some of the signs and symptoms. Risk factors for mastitis: breastfeeding, nipple trauma, cracked nipples, poor milk drainage can lead to mastitis. Clinical diagnosis, or ultrasound if abscess develops. Treatment referral. Antibiotics, example, dicloxacillin or cephalexin for 10 to 14 days can be used. Dicloxacillin or cephalexin, 10 to 14 days. Continue breastfeeding or pumping. Warm compress plus pain control. Test tip: think, just keep feeding. Frequent emptying of breast helps. Sore nipples equals normal, common in first 2 weeks of breastfeeding, improves over time. Okay, fibroadenoma is a benign solid breast tumor composed of fibrous and glandular tissue, most common in women ages 15 to 35 that are hormonally sensitive. Most common benign breast tumors in young women may enlarge with pregnancy and regress after menopause. Signs and symptoms of fibroadenoma is painless, non-tender lump, soft, rubbery, and well-defined. Mobile, breast is like a breast mouse. It's mobile, no nipple or skin changes seen. It is painless, it's non-tender lump. It is soft, rubbery, and well-defined. It is mobile like a breast mouse, no nipple or skin changes seen, and that's fibroadenoma. Risk factors: ages less than 35 years old and hormonal fluctuations, example pregnancy, oral contraceptive pills, estrogen. Diagnostics: ultrasound preferred if less than 30, plus mammogram if greater than 40 years. Core needle biopsy, if uncertain of what it is, a core needle biopsy can also be done to rule out cancer. Treatment: referral. Observation: if small plus stable, repeat ultrasound in 6 months. Surgical excision if large, painful, or growing. Let's see here. So for the mnemonic for breast cancer suspicion is ABCD, which we're going to look at in a second. A is asymmetry, B, bloody discharge, and we're talking for breast cancer, not just the melanoma type of thing. Bloody discharge, asymmetry, bloody discharge, change in skin such as dimpling or pordo orange, resemble the skin of an orange, distinct hard fixed lump, enlarged axillary lymph nodes. Breast cancer: malignant tumor of the breast tissue, most commonly invasive ductal carcinoma, results from genetic, hormonal, and environmental factors, results from the uncontrolled proliferation of epithelial cells. Signs and symptoms: hard, fixed, irregular mass, skin dimpling, pud orange, nipple retraction, bloody nipple discharge, age greater than 50 years, BRCA mutation, nulliparity, obesity, smoking, early menarche, late menopause. Diagnostics: mammogram, first line for women greater than 40 years, plus or minus ultrasound, using an ultrasound, mammogram or ultrasound. Core needle biopsy is a definitive diagnosis for breast cancer. Treatment or referral: for multimodal, you can do surgery, chemo, radiation, endocrine therapy. Oncology referral is needed. Now, mammogram screening. Mammogram is the main tool for early breast cancer detection. Begin routine screening at age 40 with interval based on risk and shared decision making. Encourage breast self-awareness, changes in shape, size, nipples, though routine self-exam are no longer universally recommended. The USPSTF 2024 begin at age 40 for average risk women, every 2 years for 42 to 74 years. Every 2 years is when you're going to do that mammogram. For the American Cancer Society, they said age 40 to 44 is optional, annual screening. Age 45 to 54, annual mammogram. And age 55, annual or every 2 years. Or for high-risk women with BRCA mutation, strong family history, prior chest radiation, etc., begin screening at age 30 and annual MRI and mammogram. Okay, we'll take a second break and then we'll continue with high-risk pregnancy disorders.